so we can start. Welcome everyone. My name is Helena. I'm the past chair of EYFDM Women's Health Special Interest Group, and today we're celebrating a webinar on violence against women doctors, along with the WONCA World Party on Women's and Family Medicine. I would like to begin with, Daria George, which is the EYFDM current president. So please, Daria.
Hi, good afternoon, everyone. It's so lovely to see so many of you joining. Thank you, Elena. So I'm speaking on behalf of EYFDM, which is the European network of the Young Doctors Movement. I will be taking the presidency in January. Our current president, Stuart, had other commitments, and unfortunately he cannot be here, but we're welcoming you all. Cheryl Chan, who is the world chair of Young Doctors Movement, she also had other commitments, but she's very happy for this webinar. Thank you all for joining us, and thank you, Elena, for doing such a great job. And welcome to our amazing speakers.
Great, thank you, Daria. Thank you so much. I would like to introduce now Hina. Is that right, Elojo?
Yeah, Hina is our president chair-elect for the Working Party, and she will be saying a few words on behalf of the party.
Thank you.
Hi, thank you, everybody, and it's wonderful to see the Young Doctor European movement for arranging this session in collaboration with the Women Working Party. Just a bit about the Working Party. So we have a global presence. In some regions, it's still in infancy, but we try and collaborate in multiple areas like academic research, arranging webinars, and obviously speaking about women, health, empowerment, gender-based violence, and workplace-related activities. Some regions, obviously, they are still in the process of kind of developing various strategies, and we are kind of actively involved in it. We are also participating in anything which is hot topic at the moment, for instance, climate change. And I'm grateful to the leadership of the Women Working Party and the entire team for building it up. So we are evolving, and we look forward to working with the young doctors in future. Thank you.
Thank you very much. It's great to have you all here. So I think we're going to begin with the presentations. We have, first of all, Dr. Abimbola Silva from Nigeria. Please, Dr. Silva.
Hello, everyone. Great to be here. Well done, Helena. Thank you, everybody. I'm trying to share my slide. Oh, hello, are you sharing for me as well? No.
Yeah, I'm sharing for you.
Okay, you're sharing for me. Then maybe I should stop sharing. Oh. Are you able to share, or should I?
Yeah, it's perfect. We can see it.
You can see the slide then?
Yes,
Oh.
in full screen, so it's great. Thank you.
Okay, let me see. Great, thank you very much. And also, yes, my name is Abimbola Silva. Thank you, Helena, for the introduction. I'm a family physician. I run a hospital in Nigeria. I have a special interest in intimate partner violence. I'm also a member of the WONCA special interest in family violence. So I'm talking from Nigeria. So basically, if we go to the next slide now, okay, so if I'm going to be talking about the situation of violence against women in Nigeria, female doctors in Nigeria, we have to generally talk about the situation of violence against women in general, because I must say there's not so much data regarding female doctors in particular, but we cannot talk about the violence against women in Nigeria without talking about the Violence Against Persons Prohibition Act. That's what we have as our legal basis to protect, to care for victims, and it describes in detail the different forms of violence against persons. It describes in detail the protection for the victims and what they should do when they're exposed to violence, and the punishments for the perpetrators. Now, despite all the legal protections, there's a lot, is what to be desired regarding the actual care that the women actually receive. There's a disconnect between the legal and the actual medical care that the women receive. So can you go to the next slide, please? So what we have is that even though the laws are there, we have a lot of civil society organizations and NGOs that try to bridge the gap and help, women to be, oh, you've skipped a slide. Yes, to help the women to be able to have access. But officially, we have what they call the sexual assault referral centers that are supposed to be the one-stop gaps, but they're not one-stop. They're not everywhere for starters. Then there's only one location in some states. There are 36 states in Nigeria. There's only one location in some of the states. Some states do not have at all. And the only thing they do is to give initial assessment and do psychotherapy. And sometimes, even if the person has been sexually assaulted, there are no rape kits. And even if the rape kit is administered, there are no DNA testing is not done. Unfortunately, while we're still struggling to, find cohesion and structure to how women receive care, the act that's supposed to support that care is now under some kind of attack, and they're about to repeal that act. So there's a bit of confusion in that regard. And sometimes even when you have a situation where someone has been the initial assessment is done, the case has gone to court, and judgment has been pronounced, sometimes the judgment is not upheld. So that's what the situation is. That's for women in general. I mean, I cannot talk about female doctors without talking about women in general. And I'm saying this to show that there's little structure as far as the care for the women is concerned, except, you know the connections, you make the connections yourself as a primary caregiver regarding, the NGOs that can connect, the NGOs that can get legal support for the person, that I guess shelters. So there's no structure per se. So it's difficult even but the few people that get the people that get attention and get help, some of it is mostly free, and a lot of NGOs are pushing for a lot of support, and a lot of work has been done by NGOs and civil societies. But that connection from medical to the legal is still a bit lacking. If you go to the next slide, please. And then, of course, like I said, there are no perpetrator programs whatsoever, only punishment for the perpetrators. Okay, so if we now specifically try to narrow down to female doctors in Nigeria regarding how we treat violence against them, I mean, once I have laid background that for women in general, the structure is not there. I want to start, looking at the female doctor in Nigeria. You have to start from the medical school, from the medical training program itself. A lot of the training, there's some acceptable psychological abuse that is almost normal as part of the training, as minimal as the superiors talking down to the younger ones in the word round because you didn't get the answer. That's there. Of course, it's also not documented. There's no data, and then there's also the sex for grades that's common in universities. Also, no actual data regarding that for medical students, but we know it exists from stories. But no, I can't give you facts and figures. HR departments, and somebody mentioned a few minutes ago about how if you have been exposed to assault, you can just go to the HR department. The HR department, it's a bit still foreign for you to report that in the HR departments in our hospitals or the schools. Like I said, the data is small or limited because there's a lot of silence. There's a lot of silence around it, the stigma. Nobody wants to really talk about it. Then the training, the lack of it, of people that respond first to those first responders to violence. In a lot of cases, yes, there's some what we call the gender-based desk, where you report violence in the police station. But then some of those police officers are not even trained. Their own biases still affect the way they respond to the victims. They may say, oh, go and settle it in your home, go and settle with your husband, settle with your boss. That's for intimate partner violence. I'm still basically trying to talk generally about women, not just the doctors. But in the few instances where those people are trained, some of them are not even kept in simple, they're transferred away from those positions. And so that service is not continuous, it's not structured. I didn't find any resources specifically available for female doctors or students on how to handle violence at work or in school because of their gender. But if there's anybody I'm looking forward to being able to hear of some of that, even as I share and I listen to some of the interactions from other people. If you could change the slide, please. Next slide, please. Or is it from me or from?
Maybe from you.
Okay, so yeah, like I said, the data is minimal. Okay, no, it's changed now. Thank you.
Okay.
Data is minimal, like I said, but if you're just talking from stories that one has heard, the situations. Oh, okay, you've skipped a slide. Yes, the situations where female colleagues have been attacked by patients when it comes to, comparing female doctors with male doctors and how they're exposed to violence in Nigeria. The situations where female doctors have been attacked. There's an ongoing story about a female doctor who was kidnapped. Yeah, doctors are attacked and kidnapped in Nigeria. But I cannot specifically say that the ones that were the stories that we're hearing now is because they were not targeted because they're female doctors. So it's not specific to the female doctor. It could also be, men have also been reported to have been attacked by and almost killed by their patients or the relatives of their patients when the treatment or the care doesn't go the way they want. That's all data there. Can you go to the next slide, please? So what I found is there was a study that was done, a systematic review it's a global study, about 13,000 studies on violence among healthcare workers, with only 226 studies that were analyzed. Of that, I think 3 were from Kenya, 3 were from Ghana, none were from Nigeria. But what they found was that women experience more non-physical violence, including verbal abuse, sexual harassment, and bullying more than men, while men experience more physical violence than women. And the risk factors that made women more vulnerable above men were if they were younger, if they had less experience, if they were working shift duties, they had a lower professional status and the level of the organizational hierarchy where they were, and as well as minority status. So, but this is not a Nigerian data. This is just what I found globally as what came out as what was an advantage or a disadvantage for female healthcare workers. Again, there were healthcare workers. This included nurses as well. And a woman, so it just runs through how a woman may present. If she was being violated, she may have frequent presentations with big symptoms, unexperienced physical injuries, frequent UTIs, chronic pain, mental health issues, behavioral problems, and overprotective partner. But if you were to relate this to a female doctor, she may hide all of this very conveniently, or she may treat herself. So, but I'm hoping that this would just be a way to shout out to let people start talking about the indicators that will give us a high index of suspicion to screen. Next slide, please. And then I'll just talk about the screening rules. If we see someone with these clinical indicators or conditions that may be caused by or complicated by family violence, you ensure that there's privacy. You ask them directly about safety at home, at work. You should use a simple tool to show support and concern. Should be non-judgmental. Provide valid support and practical care. So that means that you must be aware or be informed of the facilities or the services that are available and mobilize to show support for them. Now, because in Nigeria, like I said, the structure isn't really there. Sometimes you have to create your own structure, find what is available and know who you refer to in every situation. Next slide, please. The barriers to screening, like timing, stigma, denial, fear of what may happen. So these are the reasons why, even as a female doctor, you may not even want to disclose. You may not be able to get them to disclose the violence, the poor training of the people that are responding to the violence. And then, of course, the valid fear we may have sometimes about our own life and safety when we're asking about this. So in general, again, I'm not talking specifically about female doctors. I once had a patient that I had to discharge her right back to her husband that was a perpetrator because he was an army official. I mean, even if I were to advise her to go to the police, I didn't know what the man was going to do to me. So that fear of the healthcare provider, talking can also be a valid fear. So call to action or some points to think about. How do we make it safe for female doctors to actually disclose, especially the psychological and sexual violence that's often hidden? How do we mobilize social support for female doctors and get them to access legal assistance and increase their own safety in the workplace and at home? As well as importantly, how do we healthcare providers, especially in my environment, how do you make yourself aware of what services are available and where in the places where you practice so that you'll be able to offer that support to that person who discloses to you? Thank you very much for listening. I look forward to questions and comments rather than anything.
Thank you very much, Dr. Silva, for this very insightful presentation. I just wanted to mention that the question and answer session would be at the end. So if you have any questions, please write them down and we'll be going through with them at the end. It's very interesting, the fact that there is no data about this topic, meaning that perhaps there's not enough disclosure, although we do know that these events happen. I would like to introduce now Dr. Alejandra León from Colombia. She's also a family doctor there, and she's going to share her presentation now. Thank you very much.
Muy buen día a todos. Me permitiré hacer la presentación en español, considerando que durante la planeación del presente webinar contamos con un traductor de español a inglés y de inglés a español.
Yeah, I will do the translation from Spanish to English. Is this like on the correct channel? I don't know if like if
Well, in fact,
and
I think
speak at the same time.
there were a problem because there are a configuration where so people can change the channel to listen. I mean,
Okay.
I think we couldn't do that. So we could do this. I speak in Spanish and just wait some seconds and you do the translation.
Okay, yeah, perfect. Thank you.
Bueno, muy bien. Entonces, bueno, mi nombre es Alejandra León, representante del movimiento Waynakay Latinoamérica. Bueno, pues yo quisiera hablar considerando las presentaciones de mis otras colegas sobre cómo se relaciona el movimiento feminista con todo ese tema de la violencia de género en el ámbito de la violencia en las mujeres médicas. Y esto es importante porque el movimiento feminista ha sido fundamental en la lucha por la equidad de género y la erradicación de estas violencias estructurales que enfrentamos las mujeres en diferentes ámbitos, tanto desde la histórica Declaración de los Derechos de la Mujer y la Ciudadanía en el siglo XVIII hasta los recientes movimientos que muchos conocemos como Ni Una Menos, Me Too, pues todo esto ha evidenciado una verdad innegable y es que es el machismo, ese patriarcado atraviesa pues todas las esferas de la vida, incluso en el ámbito de la salud, que es donde nosotros nos desarrollamos. En América Latina, las mujeres médicas, que pues también son pilares de los sistemas de salud, ya que pues eh, contamos con un porcentaje muy importante de mujeres en estos espacios, pues enfrentamos una realidad alarmante y es que existe altas tasas de violencia de género, como lo mostraré más adelante, que se manifiestan, como muy bien lo decía la doctora previamente, no tanto en la violencia física, más sí con el abuso, con el acoso sexual, la discriminación, la violencia verbal, y por supuesto la desigualdad salarial, así como una constante subvaloración en la esfera profesional. Y esa problemática no solo socava nuestros derechos como mujeres y profesionales, sino que también perpetúa pues estas dinámicas de inequidad en una región que ya pues enfrenta profundas desigualdades estructurales. Por tanto, pues hablar de violencia de género en el ámbito de la medicina no es solo una cuestión de derechos humanos, sino que es una cuestión de justicia social, de salud pública y de desarrollo profesional. Toda vez que cuando nosotras enfrentamos pues estas violencias, pues también afecta la atención sanitaria que prestamos y la equidad pues en nuestros equipos de salud. Así que pues bueno, eh, daré unos minutos para que realices la traducción.
Thank you. I tried to write down. Thank you so much. I just wanted, I will be talking in the first person. So I just wanted to do this presentation, which will be in link with what the other participants have talked. I want to start talking about the feminist movement. Because it has been very impactful. It has also a very radical stance regarding the violence, the gender violence. For instance, there are the movements that the one in Latin America or in Spain, which is called Ni Una Menos, so not like at least one of us, also Me Too, which show how the patriarchy is actually involved in all the spheres of life. In Latin America, there are a lot of doctors, also a lot of female doctors. The percentage is actually very high. And unfortunately, there's also amongst these healthcare professionals a very high quote of gender violence. It's not necessarily just physical, but it can also go more than that. It can also be sexual violence, verbal violence, or also like economical and social inequality. This is actually very important because not only it affects the healthcare professionals, but it's also a question of social justice, of public health, and also of the development of the public health as well, because it actually can affect the quality of the healthcare that we as professionals provide for our patients.
Thank you. Bueno, entonces hablaré brevemente sobre las olas del feminismo y cómo éstas se han relacionado con nuestro tema de violencia de género. La lucha por los derechos básicos fue lo que caracterizó a la primera ola del feminismo que ocurrió entre los siglos XIX y XX. En estas, pues las primeras mujeres médicas en Latinoamérica, como la doctora Matilde Montoya de México, quien encontrarán en la imagen de la diapositiva, pues enfrentaron mucha resistencia tanto institucional como social al desafiar las normas patriarcales que consideraban la medicina un ámbito exclusivamente masculino. Muchas mujeres sufrieron esta violencia simbólica, acción y el cuestionamiento de sus capacidades como profesionales. Entonces, en esta primera ola vemos cómo no solamente se luchó por estos derechos básicos como el voto, la educación y la participación en la esfera pública, sino además el ingreso de las mujeres en la educación superior, incluyendo, por supuesto, la medicina en este entonces era limitado.
So I will start speaking about the waves of feminism. The first wave, which has been from the 19th to the second to the 20th century, one of the main representatives is Matilda Montoya in Latin America. So it was against violence in general in society. Women at that time were in a male exclusive environment, especially in the higher education areas. So it's more in that time, more of like a symbolic violence of where their place in society was, because the men were actually questioning their place there. So it's actually, it was very involved also like regarding voting, education, and participation into the public sphere. But it's actually more than that. It's actually giving them access. So there was like this fight to have access to higher education like medicine or other study areas.
Thanks. La segunda ola, que ocurrió entre 1960 y 1980, se caracterizó por la búsqueda de la igualdad y derechos laborales. Entonces, en esta segunda ola del feminismo, pues marcó un aumento en la participación de las mujeres en carreras profesionales como la medicina, pero pues ya con una perspectiva más de igualdad y derechos laborales, ¿no? Entonces, aunque más mujeres, lo que se observaba es que si bien ingresaban más mujeres a las facultades de medicina, continuaban enfrentando desigualdad salarial y exclusión sobre todo para la participación y realización de algunas especialidades pues consideradas de mayor prestigio como la cirugía. Entonces había una limitante marcada para poder hacer este tipo de especializaciones. Y también había violencia en el ámbito laboral. Durante este periodo, las mujeres médicas comenzaron ya a denunciar el acoso sexual, la violencia psicológica dentro de los hospitales y las universidades, y pues, como sabemos, lamentablemente es una realidad que sigue acaeciendo pues en la actualidad.
The second wave of feminism was mostly between the 1960s and the 1980s. The main movement was for searching for equality and also for working rights for women. Fortunately, the participation in careers such as medicine has increased, so there was like more equality regarding numbers. But even though there were more female students in the medical field, there was still a lot of inequality, be it related to the salary or be it related to the access of certain specialties considered as prestigious, for instance, in surgery. There was also a lot of denunciation of violence, be it in hospitals or in the university, which was mostly sexual or psychological. And unfortunately, it's a reality that we still have to face today.
La tercera ola, que ocurrió entre 1990 y 2010, amplió el feminismo para incluir perspectivas más de tipo intersectoriales, abordando ya otros temas como cómo se combina el género con la raza, la clase, y cómo éstas interactúan en la opresión de las mujeres. Este impacto, que ya, digamos, en el ámbito de la medicina, lo que veíamos es que en las mujeres médicas latinoamericanas comenzaron a liderar movimientos por los derechos reproductivos y la salud pública. Sin embargo, también se enfrentaron con violencia institucional al defender el derecho al aborto seguro, a combatir políticas conservadoras, y esto pues generó también una mella en este momento. A nivel de la violencia simbólica e institucional, pues las médicas también desafiaron las normas culturales, especialmente en temas de salud sexual y reproductiva, y pues fueron víctimas de campañas de desprestigio, incluso amenazas. Entonces, pues sí se iba visibilizando más esta violencia de género, y pues se traducía en discriminación en procesos de ascenso, violencia sexual en los espacios hospitalarios y desigualdad en la asignación no solamente salarial, sino también para recursos de investigación.
The third wave was between the 1990s and the 2010. This was the wave that was more focused on the intersectionality of feminism, which tried to understand how gender can relate with race and also with the social class, and how these elements can be unfortunately used to oppress women. This has seen an increase of women in leadership positions who are actually advocating for the reproductive rights and also for public health. But unfortunately, it came with a downside of institutional violence, which is actually preventing them to actually do all of these campaigns, be it for sexual health, contraceptive rights, or safe abortion. There were a lot of cultural norms that were into play at that time, and unfortunately, some of these women who are very vocal for these public health problems have suffered either like smearing campaigns. They were insulted or they were threatened. And that time, this was also a way of they were speaking up a bit more, and so they made visible this violence, which, as we previously said, is not just physical, but can also be sexual, psychological, also can be the glass ceiling that you might have heard of, the inequality in either in accessing like higher paid positions, also research positions.
Para finalizar, la cuarta ola del feminismo que ocurre entre el 2010 y la actualidad está marcada sobre todo por la tecnología y la lucha contra la violencia. ¿M? Entonces, muestra cómo el uso de las plataformas digitales sirve también para ampliar las demandas de los movimientos feministas y pues en el caso de cómo se relaciona con las mujeres médicas, pues aparecen movimientos también que ya conocemos como Ni Una Menos o Me Too, que han visibilizado este acoso y la violencia que sufren las médicas en entornos laborales. En Latinoamérica, pues hay diferentes estudios que han documentado tasas alarmantes de acoso sexual y violencia psicológica en hospitales y universidades. Pero pues a pesar de esto, se han liderado estos esfuerzos para implementar protocolos contra el acoso y las políticas de equidad en el ámbito de la salud, pues aunque sigue persistiendo la resistencia de las instituciones.
The fourth wave of feminism started in 2010 and it still goes on until today. It has been marked by the presence of technology used to shine a spotlight against violence, helping feminist movements fight against violence. So it's basically the use of certain digital platforms to offer a means of expressing for these feminist movements. We spoke in the beginning, and you might have heard of them, Me Too or Ni Una Menos. In Latin America, and there were still cases of violence, as in other places as well, but there have been protocols that have been put into place to help diminish the disequalities, the gender disequalities in the healthcare environment to protect female healthcare workers against violence, even though sometimes the institutions still resist this change.
Bueno, para finalizar, algunos datos críticos sobre la violencia de género en nuestro gremio. Insisto, como la doctora Ambibola ya lo mencionó, la violencia física es mayor en hombres que en las mujeres en el ámbito de los trabajadores de la salud. Sin embargo, las mujeres en un estudio de Ruanda se reportó 68% de violencia verbal, 39% de violencia psicológica en mujeres en Italia. En Estados Unidos hay una cifra alarmante de un estudio que reportó 68% de acoso sexual. En Boston hubo una discriminación del 100% reportada en un estudio y el bullying en mujeres se reportó del 53%. Si bien en los hombres había también bullying del 38%, pues siempre se reportaban tasas mayores en las mujeres.
Now I want to present to you some critical data regarding the healthcare professionals and the violence. As it has been stated before by Dr. Abimbola, the physical violence is more present in male doctors. However, a study in Rwanda has shown that 68% of female healthcare professionals have experienced verbal violence. An Italian study showed that 39% of female healthcare professionals have experienced psychological violence. A very distressing survey in the United States have shown that 68% of female healthcare workers have experienced sexual violence, and one in Boston showed that 100% of them were victim of discrimination. Also, the bullying statistics, 53% of women have experienced them. They're also 38% of male, but we can see that women are mostly victims of all these means of discrimination and violence.
Voy a mencionar, quienes deseen consultar la bibliografía asociada pueden escanear el código QR donde podrán descargar la revisión sistemática y otros estudios que presento a continuación. Como factores contribuyentes en estos estudios también reportaron las normas arraigadas de género, es decir, el machismo, entre otros, la cultura organizacional de las instituciones prestadoras de salud, la falta de políticas efectivas de prevención y respuesta ante los casos reportados y el miedo a represalias por parte de las víctimas hacia sus perpetradores que suelen tener como relaciones de poder, ya sea, por ejemplo, como docentes o adjuntos y demás normas organizacionales de las instituciones de salud.
Some factors that might contribute to this, for instance, there are the embedded general norms, there's also the organizational culture, unfortunately, a lack of effective policy of preventing and also of answering when these situations happen. And also, unfortunately, the victim might be afraid of what might happen to them because some of the perpetrators might be in a powerful position if they're like for instance if they work as professors or in high areas of society.
Con relación a la prevención, digamos que diferentes estudios lo que han demostrado es que los mecanismos para disminuir esta situación alarmante es implementar políticas organizacionales que establezcan una política, una cultura de cero tolerancia hacia cualquier forma de violencia, acoso, discriminación. Estas políticas deben ser claras y comunicadas a todos los empleados, hombres y mujeres. También crear mecanismos de reporte efectivos para que pues, las víctimas de violencia puedan reportar de manera anónima estos actos y también crear como un sistema de monitoreo a las víctimas de violencia. También hacer capacitación y sensibilización a la comunidad en salud para proporcionar pues formación regular a todo el personal sobre la identificación, prevención y respuesta a violencia basada en el género, incluyendo pues el acoso sexual, el bullying, la discriminación y pues su importancia en el entorno laboral. También hacer intervenciones a nivel organizacional, como lo mencioné previamente, fomentar un cambio en la cultura organizacional que promueva el respeto y la igualdad de género. Y asimismo, pues apoyo psicológico y legal a las víctimas, que ha demostrado también tener un impacto en la disminución. Generar políticas de flexibilidad laboral, por ejemplo, para reconocer esta responsabilidad que tienen que tienen las mujeres en términos de responsabilidades familiares, por supuesto, al igual que los hombres puede ayudar a disminuir el estrés y por supuesto hacer también investigación y monitoreo de los diferentes programas que se implementen para ver la efectividad de los mismos. Finalmente, pues promover siempre la igualdad de género, que esto implica, por supuesto, equidad salarial, de reconocimiento en posiciones y cargos y finalmente intervenciones comunitarias también son muy efectivas para pues, generar grupos de defensa que aborden estas normas culturales que perpetúan la violencia de género.
In regarding to prevention, there are several things that we can do to prevent this. First of all, it will be organizational policies, which should promote a culture of zero tolerance. It should be clear for all the employers and also for all the employees, be them male or female. There should also be easy accessible reporting means so that the victims can report this through an anonymous way if they want to. There should also should be a monitoring system. Also, it's very important to sensitize the healthcare workers on how to detect and also how to answer in case these violence occur, be it in patients or in healthcare professionals. When we're speaking about the organizational levels, it's very important to act and to try and change the cultural stereotypes, to offer psychological and legal support, which has been proven to diminish the cases of violence. Also, we should offer working flexibility. We know that women are very involved in the family life, also men are and should be very involved. And if we offer flexibility to women, this might diminish their stress. It's also very important to monitor all these actions that have been put into place to see if it's very effective. Also, we should always promote gender equality, be it in salary or in positions. Also very important should be the community interventions so as to promote this culture of zero tolerance and also to work against the cultural norms that might promote these gender stereotypes.
Finalizo mi presentación con la siguiente reflexión, y es que la violencia de género contra las mujeres médicas latinoamericanas pues es un problema sistemático que requiere una respuesta integral, con la implementación de políticas institucionales, educación en género, fortalecimiento de redes de apoyo. Todo esto es esencial para transformar el entorno laboral en uno que sea equitativo y seguro, y por recordar que como médicos, académicos y líderes en salud tenemos la responsabilidad de visibilizar este problema y trabajar activamente en la solución. Muchísimas gracias.
I wish to end my presentation saying that the gender violence against women healthcare workers in Latin America is actually a systemic and systematic problem. That it necessitates a very global response. It should be implementing institutional policies, gender education, organizational policies. And I think that we as women, as healthcare professionals and as leaders, our responsibility is to discuss about this and to give visibility to this problem. Thank you very much.
Gracias, doctora Daria.
Muchas gracias, Alejandra.
Thank you, Alejandra, for your presentation. I think it's very important to remember the history, to get to know the present, and definitely the review of the waves of the feminism is something that we need to talk about. We're going now towards the third presentation with Dr. Mary Robertson, who is a GP trainee in Bristol, UK. And I think Elojo will help us with the presentation. Thank you very much.
All right. Mary, you can go ahead and start speaking.
Yes, so Elojo will be sharing my screen for my presentation. Thank you very much. Welcome, everyone. And thank you very much for WONCA and EYFDM for hosting this topic on violence amongst female doctors. Really a key moment in terms of us recognizing this, and the first steps are to actually speak about it. Yes? Elowen, are you okay to see the slides?
Yeah, it's coming up right away.
Okay, sure.
Sorry.
Thank you.
Okay. Oh, sorry. Yeah.
Are you sharing them, Elojo, or should I?
Yeah.
Okay, great. Perfect.
Thank you.
Thank you.
Right. So, I mean, if we look at the definition of violence against women, I think many times people think that it's just physical violence, but the United Nations has basically said it also involves sexual violence, even mental harm or suffering that women may experience. And that could include threats of any such act. It could include coercion or arbitrary deprivation of liberty. And this can occur in public, or this can occur in public life. And important to remember that as much as we have violence against all women, there is domestic violence as well against female doctors as well. If we go to our next slide, we'll want to think about who is causing the violence. So it can be partners of female doctors, but also a lot of times a major amount is from patients and their extended families as well. Colleagues may also be causing the violence, and that could be of the opposite sex, or that could be of the same sex as well. It could be colleagues within the workplace, or it can also be colleagues in a supervisory or a senior position as well. And key things to note is that the institutional framework that exists in each place, whether it's in different countries in Europe or whether this is in the United Kingdom, sometimes foster that culture of acceptance or normalization of such acts of violence. And the European Junior Doctors Association has basically mentioned that these acts of aggression not only jeopardize the well-being of the individual doctors, but also it affects the quality of healthcare that our patients and our broader healthcare system experience. If we look at the next slide, I want everyone to put in the chat what your interpretation is of these images that I've put. So we have 3 images. The first one, and write what you feel. So is it fear? Is it shock? Is it apprehension? Is it anxiety? Is it, if we look in the first one, his hands are around her throat. And this looks like either a co-worker or colleague, or it could be a person in an advanced position to her. And his hands are around her throat. And symbolically as well, she has a mask on, they both do, but she's unable to speak at that point in time. And that's something that happens a lot with female doctors, the fear of being able to speak when this violence is happening. He also seems to be speaking into her ear, if you notice. So that could be forms of abuse, of verbal abuse, mental abuse, and emotional abuse. You can imagine what is being said in that scenario. In the second position, this doctor may be seeing what's happening because she may be a bystander. She could also be someone who can be an ally as a witness to what is happening in there. But also surrounding her could be the unseen types of aggression and violence that doctors experience, the written forms of communication, the emails, the unseen sort of institutional types of aggression and violence that can be happening as well. The third photo, tell me what you think about this one. So this could be burnout from the violence. This could be PTSD, post-traumatic stress disorder, out of seeing what has been happening or what she has experienced. It could be emotional overwhelm. The emotional capital of violence happening to doctors would mean that she may not be able to come to work or not want to come to work, and that affects the wider team as well. And so this violence that's happening to doctors, we need to document this. If we go to the next slide, I got this information from Liu et al. It's a world systemic review and meta-analysis on the prevalence of violence against healthcare workers. And I think it's very important in us trying to get solutions to violence against females is to collect the data to support what the problem is. It showed that 61.9% of workplace violence happens with healthcare workers, and that includes doctors and other nurses and other healthcare practitioners. But out of that, very important to note, about 25% of that is actual physical violence, and that tends to be mainly among men, but it can happen to women as well. And also to note, much higher than that, almost double at 42%, is the non-physical forms of violence. And that includes, of that, almost 60% of verbal abuse. Hello?
That's okay, Maria. Probably someone had the mic on. Please carry on. Thank you.
Thank you. And 33% of that includes threats. And threats could come in many forms. It could be, this threat could be a threat to end a career or threat to end training of a female doctor. It could be threat of defamation of character. It could be threat in giving a negative review of the assessment of the doctor in retaliation. It could be threats of future violence, not only against that female doctor, but also against her family, her children, and wider community as well. And that's some serious things to work out. If we go to our next slide, we see in our next slide, please, thank you. They looked at a 12-month global workplace violence prevalence, and they separated this by country, by gender, and it and also by the non-physical and physical violence. If we look to the other slide after this and take a closer look, we would see that it's broken down by region. So for example, Asia had the greatest number of reports from this systemic information that was collected, and it showed that the proportion was actually about 45.5%. In Europe, it's 41 reports were collected, so it's a bit less, but also it showed that it's about 32% of workplace violence that was experienced. This is almost half in North America in terms of their percent data collected, 24%, but significantly the proportion was about 59% of violence. In Australia and Australasia, we have the percentage of that as shown here. And then in Africa, we had 16 reports that were documented in this review, a little less than Australasia, 33% in Africa compared to 38%, and then 37% in Latin America from their reports. Most of the violence actually occurs in the accident and emergency department. So in the ED department, we found that that can go up to 62%. However, in primary care, for primary care doctors, there were 27 reports that were collected, and that can go as high as 30%. And many of these aggressions and so are not necessarily reported. And then you have other areas such as the psychiatric units and so. If we look at our next slide, we would want to think about as doctors and as a movement going forward as to what solutions that we can use to reduce this workplace violence, be it physical violence or non-physical violence. And there are three main areas in which we can work in this. So on an individual level, on an organizational level, and also on a societal level. And I think a lot more information is needed in terms of data and research. And depending on the region you are, certain policies need to be developed in order to have this reduction in workplace violence. On an individual level, we can think about training of doctors in terms of how we can avoid miscommunication and avoid disagreements. And so part of that is conflict resolution skills also with other patients and in our teams. And in terms of patients, avoiding overpromising what the outcome will be in a difficult situation sort of could prevent an unwanted reaction that may get very aggressive. And the communication skills that we would include on an individual level is bystander training. So if you see something happening with your colleagues, to be aware of that, as well as allyship training as well. And that technique, we can help to support individuals on an individual level. What do you do if you see this happening to someone else or this has happened to you? It's a good idea to write down what has happened and, send an email or copy of it to yourself and keep a record. On an organizational level to reduce workplace violence, and this can be an audit that someone may want to do, is some infrastructure changes. So things like having improved security systems and evidence should someone decide to go to the police if some sort of violence occurred, installing metal detectors at entry and installing alarm systems if that were to happen to prevent weapons from coming into places where we work. And that includes some management policies in terms of how we would operate. So that could be restricting the number of relatives that may enter a ward. That improves our doctor-patient ratios. And then for areas that you do have billing, having that transparent and available to the patients and to their families could avoid sort of miscommunications where this is. Very important at the organizational level is to have an active complaint redressal system. And that's because if a complaint is made, but nothing happens out of that complaint, then there is no progress that can occur. So together with the reporting systems that we'd have and enforcing a zero tolerance policy of no aggression or violence, security measures are also important. Now, the policies should be in place and enforced for managing violent or abusive behavior. The European Junior Doctors group has suggested that we have an accountability framework, and these mechanisms should be strict to reduce the violence and implement changes to reduce that violence. And then for gender-based and sexual violence, those policies will be important also against female doctors. On an organizational level as well, the culture is important. So I think that we need to address doctor-on-doctor violence, and then institutions really need to expose and eradicate doctor-on-doctor and other healthcare worker-on-doctor violence. And that includes the physical violence, the bullying, the verbal abuse, and more. And having a victim-centric approach where victims are supported and feel encouraged to speak about what has happened, I think is key to reducing violence on female doctors. And another solution could be some victim support and credibility for victims. And then that measures need to be placed for both reporting and addressing any sort of incidents of violence. And then as we're coming to a close, I'd like you to continue to put in the chat what exists in your particular region that you are from, and put where you're from as well. So if you are in the United Kingdom, for example, if this happens, you have a freedom to speak up guardian that you can actually have a discussion with. If you're in different parts of Europe, it might be your HR, or it could be through your union, defense union, and important to get well-being factors in. And there are groups that are available for that as well, to guide you and to support you after going through any sort of violence. And then finally, on a societal level, having unbiased media reporting and the policies that politicians avoid targeting the medical fraternity, I think will go a long way to avoiding other sorts of violence against medical workers. If we look at our next slide, I'd just like you to continue to put any comments and questions in the chat, but thank you very much for the violence against female doctors that we have. And we really need to take away an ethos of ending violence against women in general. Thank you.
Thank you very much, Mary, for your presentation. It's been great to talk about this. Again, it seems like the lack of data and encouraging to report it is something that it does come across everywhere, unfortunately. And we're having now Dr. Tehzeeb Zulfiqar from Pakistan, but she's working in Australia at the moment. Thank you very much.
Thank you very much for inviting me. Just give me a minute. My presentation is about sexual harassment and abuse of doctors by doctors. And this is the book chapter which we wrote. So one of our colleague, Louise Stone, she wrote a book, and it's in publication. And three of us from Pakistan, me, Dr. Hina Javed, and Dr. Humaira Khattak. So we contributed one chapter, which was a case study on Pakistan. So I won't go to the definition of sexual harassment because that has been taken by other colleagues. But one thing I just want to emphasize that it's unwelcome conduct of sexual nature. There is a possibility that the person who is harassed would be offended, humiliated, and intimidated. And also sexual harassment includes making a statement of a sexual nature to a person or in the presence of a person, whether the statement is made orally or in writing. So it doesn't mean that, you have to have physical harassment, but it could be verbal harassment or oral harassment also. And basically sexual harassment is a most generic in one culture may not be harassment society. Different, we have to bear in we're talking about sexual harassment. I've tried of three things. So there is a harassment, but men are also the victims. So mostly men comprise the majority of perpetrators, but men are also bystanders and also survivors. And in the literature, very few transgender, intersex, or non-binary cases have reported a sexual harassment, and that could be because they're too afraid to speak. So we have again in other presentation touched upon who are the people who are at risk of sexual harassment. So at personal level, there could be gender is one of the risk factor. Female are mostly, like I said, are sexually are more at risk of sexual harassment. Then minority status people, for instance, such races, ethnicities who are in minority, younger people, people with disability, or those who have low occupational status, they are at more risk of sexual harassment. And also in those organizations where process of reporting is weak, the way there are legislations are weak, or there are weak sanctions against sexual harms, those factors also are risk factors to this behavior. And finally, structural or systemic factors, such as in those organizations where there are more men, the male-dominated organization, where there is a objectification of women, or there is a culture of low status of women. So in those cases also, there are high risk of sexual harassment. So what are the effects of sexual harassment? So in a lot of literature, it says that those people who are sexually harassed, they are 2 to 3 times more likely to have high blood pressure, poor mental status, sleep issues. They have depression, musculoskeletal, they're more prone to musculoskeletal injuries. There are also, these people are under imposed isolation. Some of them go for binge eating. They drink more alcohol, and the organization levels also they're quite adversely affected by poor worker morale, because those people are under these circumstances very difficult to work. There's decreased productivity. People are more absent most of the time, and there's high turnover. So people leave their jobs more frequently in those organizations where there are high risk of sexual harassment. I'll be giving one case study on workplace harassment, and looking at the other presentation. It may be a very minor level of sexual harassment that people have encountered in their country, but this case study shows how even that level of sexual harassment can affect a person state of mental health and their performance. So before I go, I'll just talk about Pakistan. So Pakistan is a third world country. It's a low middle income country. We have about 240 million population. About 1/4 of women participate in workforce, but women in management are quite low in numbers. We have about 1/3 of the women who report intimate partner violence. And we have very high maternal and infant mortality, as well as under 5 mortality. Pakistan ranked very low on the, sorry, hold on. Yeah, Pakistan ranked very low on the gender index. We are about 123. And we have less than 50% of female doctors And these are the registered female doctors. Because if you look at the medical colleges, we have, we have about 173 medical colleges, and one medical college where we have all women students. But in the previous slide, I showed you that we have less than 50% of women who are registered medical doctors. But we have in medical colleges, 80% of the females are doctors. But what happens that once they graduate, the situation for them becomes a bit hard to continue their practice. So there is very high dropout rate after graduation. And these are because of family-related issues, employment, there are societal cultural issue, we have workplace-related issue, and a big factor is harassment by the patients, by the colleagues, by the doctors. And about 30% of our female or women doctors in Pakistan, they have faced some forms of sexual harassment. And this is a latest study that's been published. We have about 13 laws that prevent that are against sexual harassment, gender-based violence. So these 13 laws are very favorable for women, but for women have to go to report these cases against their perpetrator, and there needs to be a police case also. But we have a very high corruption in police, and police is male dominated. So the system favors perpetrator, and the women have to prove that she has been sexually harassed, which is very difficult in most of circumstances, rather in all circumstances. So this is a case study about a young doctor who was working in cardiology department. And this case became a national story. So that's why we provided this story for the book also, and I'm sharing it with you. So she was a postgraduate trainee, a young girl who was working in the cardiology department. And she lodged a complaint with anti-harassment committee. So in hospitals, we have anti-harassment committee, which is pretty recent, but we have anti-harassment committees. And she lodged that case against her senior cardiac surgeon. The surgeon, he just recently moved from overseas. And the doctor reported that on a number of occasions, she was called into his hospital, and she was inappropriately touched when he was showing her some X-ray or any other radiological MRI or something. And then so she became quite uncomfortable. And then another intern also told her that he had some comments towards her also, which made her quite uncomfortable. So then after that, she started bringing other colleagues with her when she used to go to this guy's office. And the perpetrator was quite annoyed with, her bringing other colleagues. And then she started avoiding him when that didn't work. And then this guy, he went around, he started talking to other people that, medical profession is quite tough, and if she wants to be a cardiologist, she has to pay a price for that, and it's not very easy, and sort of quite insulting comments. During the rounds, he would target her and say mean stuff to her. And then he also threatened her with defamation if she brings the complaint against her perpetrator. So her colleagues told her not to report this behavior to the anti-harassment committee because it is going to ruin her reputation. But she went ahead and she lodged an official complaint. But that didn't stop that guy working, moving to another department. So he kept on working in the same department that she was there, despite her complaint. And of course, he denied any harassment. But she was under extreme pressure by her family, by her friends, by her colleagues, that she should withdraw and to protect her reputation. And the hospital also was pressuring her to settle against the doctor. But somehow this story got media attention, and it was quite started coming in the newspapers. So although her name was kept anonymous, but everyone was curious, who is this girl who lodged a complaint against this particular doctor. And of course, I mean, she was quite distressed at that point. And her colleagues who also had similar experience with the same person, so none of them came forward. And in the end, she was all alone, quite distressed in a very difficult situation. But to her luck, the anti-harassment committee ruled in her favor, and the surgeon was terminated, and he is immediately, and he was removed from the job. But what worked in her favor was also that when they did an inquiry, they found out that he was terminated from UK also on the same grounds, and his registration was in fact cancelled in UK. But then he got in Pakistan in a very good federal hospital. He got a job because of his very strong political background. So that shows that, you know, you do things in one country and you go back to another country, and people may not know sometimes that what type of person you are. So this girl was lucky that that guy, his history was also brought forward, and his registration not only was cancelled in UK, but also cancelled in Pakistan. So for her, the short and medium term effects were she was extremely distressed. She had extreme mental anguish, sleeplessness. She had appetite disturbances, high absenteeism. So she stopped going to the hospital, and her performance declined quite a lot. But after this, I think got in favor of her, she got a decision in her favor. The long-term effects are still something that remain with a person. So like Mary just said, that post-traumatic stress disorder, then these people have difficult relationship. It's a lifelong trauma that happens with these people. And then the confidence also. I mean, most of the people who are in such situation, they have extremely poor confidence, and they struggle with their relationship, not only their personal relationship, but professional and personal, both relationships get affected. So we've been talking about recommendation, and everyone has given their recommendation. It's sort of a repetition of what it is, but it's the first thing that we need to do is to diagnose the problem. So we have to we have to change the culture, right? And the culture meaning that we start first, we have to diagnose the problem. What is the problem? Why some people, or why the weaker people, be it women, be it transgender, be it younger people, they are exposed to this situation. The other thing is that we have to prevent happening. So the first thing which I think the first presenter also talked about was that in medical colleges, this thing needs to be taught in medical colleges. And a lot of studies have said that, you know, medical students have no idea of such things happening when they start practicing. So not only it has to the training should be for employees to ensure everyone has a common understanding of the roles and application, but this thing should go back to the medical schools also. In medical school also, we need to prepare the students in what to face in their future. They have to have a skill development to recognize and respond to sexual harassment. So need to have some training, and we need to have safe work policies that brings confidence in women, even in men, and in all those people who are at risk. For the secondary prevention, we need to identify high-risk situations. So what are the situations where people are more likely to have sexual harassment or any kind of harassment? We need to support high-risk targets, and also manage these people who are perpetrators. The tertiary prevention, so it's laid down the same way. We say primary prevention, secondary prevention, tertiary prevention, and quaternary prevention. So the tertiary prevention is when things have happened. So, you know, we have to reduce the reporting barriers and streamline the process of reporting. So once it happens, then what to do? So we have to have the processes such that the reporting barriers are reduced, and the people who have been sexually harassed, we provide rehabilitation to those people. So providing them psychological support, providing them social support, providing them with such an environment where they feel confident to go back to the practice. And finally, the quaternary prevention and promotion is to, once that has happened, once we have rehabilitation also. So the privacy and confidentiality is such that, even when a person is rehabilitated, that is one thing that everyone is scared of. So we need to have policies which maintains privacy and confidentiality, reduces victimization, reduces re-traumatization, and in restoring safe culture, safe working practices. So that's all from me. There are just two quotes from anonymous survivors. So one of the quotes says that tolerance of sexual harassment must not continue to be the price that the women pay for career in medicine. And I think this is a very high price that women pay to be in a career in medicine if they are sexually harassed. And the other quote is that there isn't anything you can be, do, wear, or say to stop people harassing or assaulting you. The only thing that predicts any person being victimized is being next to an unchecked predator. So I think that unchecked predator is something that we need to identify, we need to check, and we need to ensure that people do not feel that they have the right to do such behavior. So that's all from me. Thank you for listening, and thank you for providing me an opportunity to present.
Thank you very much, Tehzeeb, for your presentation and your insights on the topic. It's been great to hear from all of you. I think we can allow now about 10 minutes to questions and answers. There is a lot of questions on the chat, so we're trying to go through them now. Is anyone that would like to speak up at the minute? Just open your mic and go through. Otherwise, I will read some of the questions on the chat.
Hello to all speakers, and thank you very much for your different presentations. I'm Suzanne, I'm from Switzerland. I actually had a comment to make about, there were things that were asked about what should you do if somebody actually physically tries to do something to you, and it's something that has been taught in certain contexts, as in, I think it might be an interesting idea at some point either to do a workshop or something explaining to those who maybe don't have access to the information what you can do, because there are things you can do. It's the same as somebody being harassed in, say, a piece of public transport. If you're a bystander, go over to them. Don't just let them sit there alone and be, aggressed or annoyed by that person. People coming towards them makes the person who's doing the aggression feel very awkward and can even stop the aggression. Everybody's always afraid to get involved. I find that extremely, well, somehow terribly fake, because sometimes things aren't necessarily very, very, very obvious or very violent, but the person being aggressed feels awful. It can be something very small, and the fact that you intervene makes it a lot less nasty. The non-intervention is almost complicity to it. Another thing is, somebody who is aggressive, you can actually take them on head on when they're alone. Because believe me, with a team of people around them, they're always much stronger, because bullies are strong when they have a crowd and when they have somebody watching. My mum was aggressed by somebody at work over 30, 40 years back. And her way of doing it was to wait. It took over a year and some. The guy entered the elevator with her one day, and she stopped the elevator. She simply pressed stop, the stop button, and said to him, "So now get it out, pull your pants down. You wanted to do this and this and this with me so and so many months back, whatever. So go on, get on with it." And he went the color of the walls. And he was sort of trying to fumble around and find the buttons for the elevator to make it go again. And he was sort of, "What are you talking about? What do you mean? Blah, blah." The kind of thing of the surprise effect and the fact of simply calling him out on it and saying, what the hell do you think you were doing? I've told everybody in the building anyway what you've done, so everyone knows, and you do that again and I'll go further. Not just standing by and sort of freezing up when these things happen. Those are sort of two things that crossed my mind that I absolutely wanted to share, that if you do actually speak up, say something, it might just make a difference. There. And apart from that, the redressal system that Mary mentioned, or the fact of having education of the male colleagues, you know, that this isn't the way you're supposed to treat your colleagues, female or otherwise, makes a heck of a difference. I had a boss years ago who was really, really neat about it. When I went and said, look, this patient tried to do this and this to me, he immediately switched me with a male colleague so that the guy was only taken care of by men from then on, because he came from a country where he seemed to think it was okay to, you know, do whatever he wanted with women. And I simply said, I'm sorry, I'm not going back in that patient's room. He's disgusting. And the guy said, yep, no problem, I understand. And if that's the response you get from your boss, it changes everything, as opposed to somebody who just sends you packing and says, you're talking crap, or you're exaggerating, or you're overdoing it, or no, you know, you're just fussing. There are things which have to come from above, from you know, from elsewhere. That is my 2 cents on it for the moment anyway. I'm thinking about what maybe could be a future workshop thing, you know, discussion to have in some other context, simply with concrete tools, because the tools exist. They can be.
Thank you, Justin. Yeah, no, I think you're absolutely right. I think that in some cases, the consequences of reporting, as you said, the good answer from a boss can, you know, can support you. But if someone does not reply as they should, then it's something that we need to address. I'm just mentioning this because on the chat there was some, you know, some mentioning that, you know, sometimes if someone makes a comment, whether, you know, it's just brushed off under the carpet, and, you know, no one, sometimes our comments as potential victims are not taken seriously, and I think that can make a whole difference. Any other questions?
Lara raised her hand.
Yeah.
You can see.
I was hello, good morning. I was talking on the chat about the situation that I endure when I was younger. When I started practicing, a colleague arrested me during an examination of a patient, and it was very delicate because I could not respond or do anything. And the patient had a very serious diagnostic cancer of the colon. Afterwards, I was very divided if I should address it with the boss, because the boss liked him a lot. And I decided to speak up with a friend where I work, a colleague, another doctor, a female doctor, and we both decided to address it, and we confronted the guy. He was a very big guy, like 2 meters of high, very, very big. And he was very uncomfortable after that, and he decided to never address me again. So it was a relief for me. But it was very difficult, and in my opinion, I think it's better for us always speak up, even though we cannot, in some contexts, speak with our bosses, but we should speak with our colleagues, with our women of trust, our family members, so that we are not alone, okay? That was my point of view. And I work in Portugal, in Lisbon, a big city, in a very desert place of Lisbon. Tá caladinha, filha. So it is very difficult to have female co-workers sometimes. and it's very important to have a good relationship with them. Okay, my opinion.
So thanks a lot for mentioning that you actually dared go and speak to somebody about it, because that's exactly it. That's 50% of the battle already won. The fact that you decide to do something, to say something. I have one ex-boss in one particular context. It took 2 external audits. By the way, that is also a method of possibly getting somebody ousted who is a problem. It took 2 external audits to get an entire team of nursing staff, in this case, midwives and nursing staff, to kick this guy out, who was literally half of the boss level on the same level too, and who was horrible. I mean, to any women around him, to the point of I've had people sort of say to me, "Why do you let him speak to you like that?" And speaking was just one problem. I mean, speaking, having instruments,
nurses have more experience in this area than us, and sometimes they can help us. In my experience, they are very aware of aggression and those negative comments that are endured. So they have more experience than us. So it's a good way to have some help in our places. Rita, não. Agora não, amor.
Because on top of it, it had legal consequences for him. He got demoted. It's like the person that Dr. Oh gosh, I've forgotten her name. The last speaker, sorry. She mentioned that this person lost their registration both in the UK and in Pakistan. That's not nothing. That's something that the person's being hit over the head with for it. And that's good. That's the way it's supposed to be. But it doesn't happen if nobody ever dares go through with it and sit it out. I mean, it's horrible what this colleague went through to get to that stage. But thank God she held on, because otherwise nobody ever gets punished if you just back down.
Absolutely.
Right. I see a raised hand. I think SN would like to speak.
Hi, thank you. So I'm one of the GP trainees here in England, and I faced difficulty at workplace, especially in the orthopedic department. So where like the male, it is quite male dominated, and they can be quite, very nasty at times. And when you raise concern, it is like, oh, there's a cultural difference, and I think everything is okay. And then they just whisper among themselves and they laugh about it behind your back. And it is such a not an acceptable behavior. And you go to because I'm a GP trainee, and I go and speak to my rota coordinator. Why is that I'm posted over here when I'm not, when it was not agreed in the beginning, like this is not my posting. And they're like, oh, it depends on the type of chocolates you've given me. They're not understanding the situation, what is happening, why I'm coming to them and speaking to them about the difficulties I'm having in this male-dominated department, and I'm not able to speak to any other colleagues and making them also feel uncomfortable. And I'm making sure, they're also safe, I'm also safe. I'm coming and raising concern. I went to HR as well, but they're like, oh, you're making a serious allegation about the doctor. I told like, these are the facts. And I'm unable to work having this man around all the time. And it is going to affect the patient care. He's a consultant. I'm a GP trainee. Of course, I need to go to him if I need help and make sure, the patient care is not affected or anything. And oh, are you going to make a written complaint, or is it just a verbal complaint? I told it's a written. So is it going to be a formal or informal? I told it is going to be formal. It is going to be a written complaint. I'm going to do it right now. And this is what I mentioned. And I had to speak to my educational supervisor. Can you please post me from this particular department to some? It is making my life very difficult and to work in this department. Oh, if you're going to ask me to post, it will be very difficult. The lady who's the rota coordinator, I don't want to take her name. So, oh, you can ask her. And I go to her, she's talking about the chocolate box. If I go to him, he's talking about nothing can be done. And he's like, if I told can I just go less than full time so that I'm not spending more time in this department, or they're like, if you're going to go less than full time, your training period going to be extended and you're going to spend more time in this department. And I was like, what sort of excuses are these people doing and going on? And they don't even respect that somebody is going through some problem. They're at least taking strength and trying to highlight what is happening. And I also had heard about this particular department where they had mentioned, like, one of the doctors, because of their sexual harassment or something that has happened, they were reported to GMC and something happened to their job and everything. And this is something else going on as a trend, I think, in this department. Nobody was taking me seriously. I literally was suffering from nightmares, and I was literally sweating most of the nights, waking up like what this man is going to do next day. I was a full-time trainee, and I couldn't take it myself because nobody was taking me seriously. I literally had to go off sick. I went off sick, and they're like, and I think because I went off sick, or they escalated that matter, he just wrote an apology letter that he was having fun with me, it seems. I was like, am I working in an NHS organization, or am I working in a pub, or am I working in some sort of restaurant that he needs to have fun with me? It is a trainee and he is a consultant. You need to respect your relationship as a professionally. You have to maintain that dignity. Well, it was such a horrible experience. This is not the only experience, and there are few nasty people in my placements in different places. And anyways, this is my experience. I just wanted to share. Sometimes you become so helpless, you just have to go off sick. Nobody is helping. Late on, you go off sick, then somebody comes and speaks to you and something happens. This is how things are very slow. Nobody even takes you seriously. It's a horrible, horrible environment sometimes in NHS, I'll tell you.
Really sorry to hear that. It's really sorry. It sounds like a real nightmare.
Yeah.
Have you? I'm seeing some comments on the chat that you might find some help with. In the UK, you've got the Freedom to Speak Up Guardian. There's a union and TPD that can be helpful. That was a post from Mary Robertson. So if you want to get some help from her, you can. Or
yeah, thank you. I did speak to, because there were so many things going on in that, because patients were dying, post-op bleedings were not reviewed properly. There was a lot of other patient care things I had to escalate even to Freedom to Speak Up Guardian, because I'm a personality where I don't keep quiet. I just knock on different doors, whichever door is going to open. I did speak to Freedom to Speak Up Guardian, but it was not a helpful thing for me at all. It was very difficult. They were not replying properly. There was no proper response. And I had to take the BMA, I'm a BMA member. I had to take their help as well. And something was done about it. I don't know, but he's still working. But I have gone through a lot of trauma because of that particular gentleman, and a lot of patients were neglected, I'll tell you. Patients were dying.
If this colleague of yours is still at work, and the hospital that or the place you were working in seems to have such a culture of silence and letting this person function in spite of what you've tried to signal or escalate, something's wrong. That you go to the right people, you tell them this and this and this is happening, and nobody reacts. At some point, you have to be able to go above and beyond that, as in go to the GMC or whoever the hell it is who has, there's always somebody above these people. They are not invincible. They are not completely untouchable. That is a myth that you have to break in your mind as a woman working in any field, in medicine anyhow. But nobody is untouchable, nobody is invincible. And believe me, that pedestal, they can come down from it and they can be pulled off. If you can bring down a dictator, the Saddam Husseins of this world or whatever, you can definitely bring down somebody who's making everybody's lives hell, especially if there's patient negligence going on beyond it. There are 1,000 other reasons than just the sexual harassment that you can bring to bear to make this person feel extremely uncomfortable continuing to work. Please don't despair, don't back off.
Yeah, this gentleman, his behavior towards me was not at all accepted. On top of it, I could see him kissing another consultant, lady consultant, she may be okay to take his kiss in a doctor's room and like other people around. Like I was like so scared that like, where he may do that to me as well. Suddenly, some men go crazy. I don't know, they've gone through some type of crisis or something. Oh my God, I used to see all sorts of nonsense and I was like, I can't take this anymore. I just, anyways, like, yeah, anyway, they saw me as a problem maker or anything. And when I escalated it to the orthopedic college tutor of that particular department, he was like, oh, this is cultural difference, I think, because I know I'm an Indian and I've been here for last 20 years. And he's talking about, oh, this is because of cultural difference. You're not able to accept it. And I'm like, what type of language are you even speaking? You're a colleague of mine who should be supportive. Just because you're a male, I can't accept what you say. I was just thinking all of this in my mind. I thought like, no, you're speaking to these sort of people. You are encouraging such department and you're encouraging such colleagues so you can stay in the department. I'm going to go off. I thought in my mind, I just went off, say they can do what they want.
I would like to say something else. I don't know if is there anyone before me or can I speak? Silence. In the cases that we feel the pressure, like we are talking about, we can speak to our superiors, the hierarchy of medical career, and we can also go to the union, and every department should have a representative working on.
There's no other hand raised, so we can speak against Lara. Thank you.
Estão arrumadas, não vais comer mais, estás cheia de aftas. Ai, tu estás demais, filha.
So, Lara, did you want to say something or did you finish your phrase? Or
I don't know if you heard what I said.
Can you just repeat, please? Because it was not very clear.
I was I have my little daughter and she's very loud, so
No,
I
fine.
was trying to say an extra about the situations that we are talking about, because in my career I decided in some cases to report and in others not to report. But if the people need to report it, we have a representative in every workplace of the Department of combating the violence. So we should report those situations. There is also an anonymous organism where we can do a complaint to the workplace to be investigated. And we can also go above the hierarchy. So if we are being arrested by a superior, we need to go above it. Okay, so it's always the way to go. Never to not do nothing. Okay, because in that case we become isolated and the aggressor becomes stronger. Okay, and if you like the subject, we have a lot of manuals and articles about mobbing in the last 5 to 10 years, and the phenomenon unfortunately has become more frequent. Okay, so the mobber will always have smaller mobbers with it, and if the victim remains silent, the mobber increases his power. So the way to go is not to be silent. Okay.
Yeah, and usually there's more than one victim. This this happens to, if it happens to you, can happen to anyone. I went through as well when I was a student through something different, and actually there was a doctor that was harassing all the students, all the female students. So we had to speak up and report, and he was taken off this place. So this is transversal, but it's true that sometimes some people can react as freezing instead of speaking up and breaking you know,
Yeah, it's
breaking the walls
normal.
and open the doors and just say it. But
So it's the way to go. Yeah.
yeah,
Thank you.
I think it's important to bring this topic out and say that, you know, we can all relate to some case, either to ourselves or someone else. So, you know, violence is transversal. It affects everyone and every type of profession, really, not only just the medical profession. But yes. We need to get this to a closure. Unfortunately, time is running. Any last question or any last comments? I just left the email on the chat group. If anyone wants to keep going with the discussion, we can always reach there. We can always try to make a different webinar at some other point with other speakers. If you want to be a speaker, we can also arrange for that. Or any questions, any comments, we can redirect to the speaker in determined. So I've just left the email on the box. If you want to take a picture or a screen, please feel free to do so. Anyone else wants to speak up now? It's now or never.
I just wanted to.
The male participants wanted to say something in the chat. He put a
Can
comment.
I talk?
Your mic. Thank you.
Can I talk?
Dr. Shaukat, go very briefly, okay? We are winding up now. Thank you.
Assalamu alaikum.
Good
evening. Good evening, everyone. This is a nice meeting, and I appreciate this meeting. As a male doctor, I appreciate you all females. You are talking the right place, and I appreciate again. This is happening in also in our country. Here is senior doctors. They are doing work inside the hospital, and some PG students, yani trainees, they are doing work under them. So I saw many doctors doing harassment, female students and doctors. So this is the right meeting, and appreciated to all. And also I am talking about Pakistan. So maybe you people arrange like these meetings, and we will reduce this harassment from everywhere. Thank you.
Thank you.
And time, Dr. Shaukat, do raise the voice and concern about it. Thank you.
Thank you so much.
Thank you very much. I just wanted to thank you, everyone, from attending today. I want to thank the presenters, Abimbola, Alejandra, Mary, and Tehzeeb from coming up to here today. Eloho for helping us organizing and hosting the webinar. Dr. Hina as well for your kind speaking earlier. And from EYFDM, I want to thank Daria and Stuart from them support. Also the translators, Miao, Fabiola, and Daria as well. And not to forget the the Young Doctors Movement, Sanka and Cheryl from the support. It's been great. My name is Helena, and I just want to thank you all from coming up today. Have a good morning, afternoon, evening, or night, depending where you are. It's been a pleasure. Thank you very much.
And thank you very much, Elena, for organizing, hosting, and moderating this webinar. Thank you for your hard work. It was very, very interesting and very useful. And thank you to all the presenters and the participants.
Thank you all. Have a good one. Thank you.
Thank you.
Bye.
Thank you.
Bye.
Bye. Thank you.
Bye.